Okay, hi everyone. My name's Eve. I'm a doctor working with BSW on the implementation of the end of life integrated care record. This is a teaching session that hopefully for lots of people I will have got round to being able to deliver it to you in person. But if you've not been able to attend the teaching, would like a recap on what was covered, or you'd like to find out more information about the end of life ICR, this is the presentation for you. So we're going to go through some slides today, just navigating through how to get to the end of life ICR, what it includes in the form, what the mandatory fields are, a little bit about the end of life ICR dashboard for general practice, and normally I would offer the opportunity for any questions, but you can contact me at any point via my email. So the Integrated Care Record is a platform across BSW that all organisations can access, that pulls in information from lots of different organisations' records. So from the community, from primary care, from the acute trusts, all of these places all feeding in information that can then be shared and accessed in other organisations. So just looking at sort of the different organisations within BSW, you can see here that lots of different places, GP practices, the acute trusts, social care, and the community and mental health teams, including the out of hours teams, all feed in information into this ICR. And then other organisations are able to pull information off of it. So whether you're a general practice team member and you're looking to find out more information about hospital letters, or going onto the digital respect, or if you're in the hospital and you're wanting to look at the GP problem list, or the regular medications, there's lots of information all hosted on this integrated care record, the ICR, that can be helpful for everybody across the system. I like to start with just a few definitions just to make sure that everyone's aware and familiar with the same terminology. So GraphNet is the UK supplier of the integrated care record and the population health software. So essentially GraphNet is the company. CareCentric is the software that provides the integrated care record, and the single sign-on aspect of it, or SSO, just means that from any of your organisations, you can go through your host clinical record system in order to get through to the ICR without any extra additional sign-ons. Sometimes if it's the first time you've ever used the ICR, you will be asked to put in your details, but that's a one-off situation. The rest of the time, you'll just be able to click through and access it in the normal way. Sometimes an ICR can also be called a shared care record. That essentially means the same thing. And when we're talking about the end of life ICR, which is what we're going to be talking about today, people might be familiar with the term an EPACS. So it's an electronic palliative care coordination system. And in our area, that's what the end of life ICR is. So hopefully that's all clear and we can carry on to thinking about what the end of life ICR is. So the end of life ICR, which in this presentation is summarised with the acronym of EOL ICR. So that's what we're talking about. It's a care plan that's accessible across BSW. So if you're having advanced care planning conversations with your patients and want to be able to make sure that that information can be shared across care settings that your patients might be interacting with, then this is the perfect place to be documenting. It's designed for whole MDT access, so from, again, general practice, the acute trusts, hospices, community services, and the out-of-hours team. So everybody in the system can view and edit this end-of-life ICR care plan. And from a general practice perspective, anybody at your practice that has an end-of-life ICR will automatically populate into what is called the dashboard. So you have an up-to-date list that's automated, does not rely on any coding, just on the fact that someone has an end-of-life ICR that's been created by any of the organisations within those bubbles on the screen. So if a patient is seen in the acute trust and someone starts an end-of-life ICR, the next time the GP pulls up the dashboard, it will include that patient on the list with some summary information. So it's a really helpful way to automate the process of palliative care registers. The benefits of the end-of-life ICR are that it helps clinicians to make decisions at critical times. So when we're thinking about whether that's patients who are at home and there's a respect form that says for ward-based ceiling of care and not for CPR, but actually then there's this end-of-life ICR that has much more detail about different treatment escalations, specific decisions relating to specific medical treatments, and more information on things like preferred place of care and preferred place of death. That it means that together, combined with the digital respect, you can get a full picture of the patient's wishes in order to direct the clinical decisions at that time. This hopefully means that patients can be cared for in the places that are important to them and in line with their previously documented wishes. It's hoped that this will lead to a reduction in unnecessary ambulance journeys and hospital stays for people who have clear wishes that that's not what they would want in their treatment. From a patient perspective, there was feedback when this form was being designed that having repetitive conversations about advanced care planning has an emotional impact on patients. The benefit of this means that anytime someone then introduces themselves to a new service, that the person providing that care can be already familiar with the conversations that have been had around advanced care planning, so you can meet the patients where they're at. It means that you don't have to start from the beginning with conversations and can pick up where previous clinicians have left off, meaning that you can just update things that are relevant to the conversations that you're having. Overall, on a system level, this means that hopefully there'll be better coordination between services, meaning that we can make the most efficient uses of the services that we have. So where are we at the moment? There's been a huge amount of progress in the end-of-life ICR numbers over the last year, particularly, but since we launched the end-of-life care plans going live. So up to now, there's been over 3,000, so nearly 3,500 end-of-life ICRs created. And currently, so this was data from up to the end of October, there were 655 forms that were live across the integrated care record at the time of this data capture. The views up to now is 21,478. So hopefully, it's understandable that similar to Respect, that a patient will have one form initially created and then it will be viewed and edited from after that point. So that sort of explains the differences between the creations and the viewing numbers. We're really pleased with the progress that has been made so far. So thank you for everyone who has currently been, working really hard to implement and integrate the end-of-life ICR into their clinical practices. But we hope that these numbers will only increase, particularly when we can get teaching, in this way across to lots of different people in lots of care settings. So how do we get to the end-of-life ICR? This teaching session is designed to be appropriate for anyone in lots of different organisations. So there are slightly different ways of accessing it depending on what your clinical system is. So within your system, you need to navigate yourself to the end-of-life ICR through the general ICR. So just an example for System 1 users. So if you're in general practice and you're using System 1, you have to look for this I icon. That's the ICR GP button, but it can also be typed into the search bar on the bottom left of System 1. That will bring you up to the main landing page of the ICR. I know, for example, in Salisbury, that this is a little sort of icon of the world that's on the top left-hand side of the screen, or in Swindon, at the moment, you go to the GraphNet button that's in the menu. So depending on what your organisation is, that impacts how you navigate to the ICR in general. Once you get there, you need to go to the care plans section, and then that's where you'll find the end-of-life ICR. So what that looks like is currently navigating to the care plans button that sits on this little banner at the top of the screen. It's right next to digital respect on this, so it's really helpful when thinking about both of them together. So once you've navigated and clicked on the care plans button with that little box with the tick, then you will come up with the screen that you can then see below. The end-of-life ICR is the bottom right, don't know my right and lefts, and you can see there that you can click that button, and that one is the one you go to either view if there already is one, or to start one, as in this screenshot. You can see that one needs to start. So you click to start and that will bring you up with how you used to get started. So First thing to cover is thinking about consent. So anybody who has consented to the ICR in general, the consent for this form is covered within that consent. So you don't need to explicitly ask for consent from your patients to be able to upload information onto the end of life ICR. However, it is really helpful to tell your patients that you are documenting their advanced care planning wishes on a form that's accessible by multiple organisations that will be able to access it if you interact with that service later on in your care journey. So that covers consent. As you can see from this screenshot, hopefully it includes all of the things that you would normally have a conversation about in your advanced care planning conversations. So it covers everything from diagnosis through to preferred place of care and death, anticipatory medicines, life-sustaining treatments, MDT review documentations, and when the next review may be. I think it's important to say that this is an extensive list of things that can be discussed as part of advanced care planning, but there isn't a pressure to complete the whole form in one go in the first time you interact with a patient. So the number of mandatory fields at the moment, there are 3 mandatory fields that are relevant for every form that's filled in. Once you've filled in those mandatory fields, and then anything else that's relevant to the conversation that you've had with your patient, you'll then be able to click save and can add to it and update it and amend it as time goes by, as will other people in other organisations once the form has been started when they then meet the patients. So rather than going through every single question on the form, I think it's the most helpful for anyone watching this to then go away, look at the form themselves, familiarise themselves with the content, and have a go at starting a form for a patient. That is the best way to get familiar with the things that are included on the form, and make sure that you can then think about how you're going to integrate it into your practice. So for this video, what I'm going to do is just go through the mandatory fields so that you know what's required in order to get started with an end-of-life ICR. So the first field that you have to fill in as part of the mandatory fields is the end-of-life diagnosis. It's a drop-down box that's got plenty of options to choose from, and there is the opportunity to add more detail about for example, the patient's conditions, if there's more than one, or if you were in a specialist team and had specific diagnosis-specific information that you think would be really relevant and important to include. And this comes up right at the top of the form. So it's really helpful when you're then looking at the form to know straight away what the diagnosis is and any specific information relating to that diagnosis that the previous clinician has wanted to draw to your attention. On this screenshot, I've included frailty just to say that it is really important that we think about cohorts of people that would benefit from having advanced care planning conversations documented in a shareable form. So often people with increasing frailty and multi-comorbidities are interacting with lots of different services across the system. So I think they're a really helpful cohort to think about when thinking about how to expand the use of the end-of-life ICR. The next thing that I've included on this slide that you can see is the gold standard framework stage, or the prognosis. Now, this is not a mandatory field to complete, and you don't have to choose one of the drop-down options that you'll see below. However, if you do choose one of the prognosis options, it becomes a mandatory field to say who you are, what your role is, and what date you said this. This is just really helpful for people in the future who are interacting with the form and, helping patients along the way, that they can see exactly when a prognosis was given and update it based on the clinical picture that's in front of them. It just helps to give context and to understand exactly where the patient might be in their journey. So the second and third mandatory fields are the preferred place of death and a summary of what's been discussed with who. So the preferred place of death is a drop-down option, and there's lots of options that you can choose from, including if you put other, and then you can free text some options of what you've discussed with your patient. Some people don't discuss preferred place of death in the very first conversation with patients who are not, say, imminently close to the end of life. And there are options for that as well, so that you can still move on with the rest of the form. So there's an option to say not discussed at present, or patient undecided, depending on what conversation you've had and what's appropriate for the conversation that you've that you've had with the patient. So there's lots of options. It is quite flexible, but it is a mandatory field that it's completed. But if possible, we'd like it for people to be having these conversations openly with patients and for it to be documented so that we can, hopefully allow people or facilitate people having their preferred place of death achieved. So the final mandatory field, as I said, is a summary of what's been discussed and with who. It's possible here that you can write more nuanced information about the conversation that you've been having, and there is a sort of a character limit, but it gives you a bit of a space to write more nuanced information. A lot of the form is tick boxing, and there isn't lots of text opportunities, so this is a good place to put any extra information that you think would be really helpful for yourself or other people who are interacting with the form. But you can just write that the patient was present and anybody else that was present for the consultation and move on. So the end-of-life ICR, we want it to be used in tandem with the digital respect forms. So in that way, you can click between them. So in the end-of-life ICR, if there's a digital respect form that already exists on the ICR, you can click on the View Respect document and it will pop up with the digital respect form. It's a good opportunity to make sure that the digital respect and the end-of-life ICR are aligned with what they're saying, to make sure there's no discrepancies between them. If you're filling out an end-of-life ICR for the first time and you get to the respect section and it doesn't say View Respect document because there isn't one, it's also a really good opportunity to complete a digital respect form so that everything is consistent and that the decisions are documented in the really important places. I like to draw people's attention to this life-sustaining treatment section of the end-of-life ICR, because I think it's a really helpful way to structure some conversations about treatment escalation for specific treatments. So should a patient's clinical condition deteriorate, what would be their views on whether it would be appropriate to have an admission to hospital, or for IV fluids, or for IV antibiotics, or for NIV, for example? This isn't a mandatory field because not all of these things are things that people would be discussing in every single conversation. So it's important to note that you can just choose the ones that are relevant to the patient's conversation with the patient that you've had. So if you were just to click yes or no for 2 or 3 of these, if that's what you've discussed with your patient, that is absolutely appropriate. But it's a really helpful place to know that if you're, making decisions about patients' treatment escalation, that this is where to look for some really helpful information about decision-specific information. This is just for anyone that's watching this in general practice, that this is the code that can be added to System 1 to highlight that there's an end-of-life ICR that's been created. The System 1 and end-of-life ICR don't automatically pull clinical information between the two. So it's important that if you're going to be documenting on the end-of-life ICR rather than in System 1, because it is all part of the patient's record, that you can add this code onto the GP system so that everybody knows to then navigate to the end-of-life ICR to look for that information. I'm just going to spend a moment talking about the dashboard, because whether you're in general practice and are going to be using this dashboard as part of your palliative care register and your GSF meetings, I think it's also really helpful for people in other care settings to understand how this form can be used in the community, because I think it helps us in terms of thinking about how we're filling it in and then understanding how it's going to be used by everybody. So as I said at the beginning of the presentation, anybody that has an end-of-life ICR at a specific practice will appear on that practice's end-of-life ICR dashboard. And this is what it looks like. So it formulates automatically a table that has the patient information and then pulls some information from the end-of-life ICR specifically to give a summary of some of the key things that are relating to the advanced care planning conversation. So I'll just pick out a few, but it's got diagnosis, does the patient have a carer, what's the CPR decision, are there anticipated medicines? So there's lots of really helpful information that you can get in one glance looking at patients in your GP practice. The colours that you can see on the screen relate to the GSF stage or the prognosis. So whilst it wasn't a mandatory field to fill it in, if you're in any care setting, it's really helpful if you can fill in the prognosis, aside from the benefits of discussing prognosis with patients, that you click on a prognosis that you think is appropriate at the time that you're seeing that patient, because then that relates to the colour that they'll see on the dashboard and helps them to adjust their conversations in their palliative care meetings to be in line with clinical needs and people who may be closer towards the end of life. Because we're talking about trying to think about extended cohorts that might benefit from these conversations, so thinking about frailty patients, it may not be that that's appropriate to discuss those patients in all of your palliative care meetings. So the additional function that you have here is the filtering function according to the prognosis. So you can filter according to the GSF stage in order to highlight the people who are closer to the end of their life that you may want to focus your time in your meetings discussing. One of the huge benefits of this dashboard is that it's an exportable table, so you can export it into an Excel sheet. And in that sense, it's a complete audit already done for you, which can be in line with the Daffodil standards, which is the RCGP end of life standards, and can help you with any quality improvement work that you might want to do in the practice. The best way to get to it is via another eye icon. It looks exactly the same, the little picture as the eye, but it's called ICR dashboard instead of ICR GP. Again, you can add a button to your practice toolbar to click to that directly, or you can search for it in the search function on System 1. On the first time that you access the dashboard, you will have to put your details in, but it's not a login, it's just a register of people that have access. And you only have to do that one time and it won't happen again. So that's how you access the dashboard. Once you get onto it, it's quite explanatory. You just click on the tab that says dashboard on the screen and it will bring up for your patients. You can right click on the patient's name and then click view patient record on that option, and it will bring up their end of life ICR and you'll be able to review it then. And the best place to document your MDT meetings or your GSF meetings, this is in any setting, whether that's hospices, acute trusts, or general practice, is within the form at the reviewed at MDT or GSF meeting summary box. So you can write a free text of the outcomes of that meeting that will be viewable then across the different care settings. So it's a really helpful place to document MDT. So thank you so much for listening to this overview of the end of life ICR. Hopefully you've got some more clarity now around what it is, what the benefits might be, how to access it, how you might go about filling a form, and what the GP dashboard functionality is. If there are any questions, please do reach out to the team. You can contact myself on the email address gwh.eolICRCF@nhs.net. And I'm happy to take any questions. If there are any technical problems, I can direct you to the BSW team that might be able to help. So please do get in touch, particularly if you have any feedback that you'd like to share with us, or any positive feedback. We love to hear constructive and positive feedback and good examples of things that you've done to implement it into your practice, and stories of what's worked well, particularly if there's anything that's worked particularly well for patients, and any benefits that you've experienced. So positive or negative, or constructive I should say, please get in touch, and we'd be really happy to hear from you. There is a QR code here. It'd be really helpful if at the end of this talk you could just follow the QR code and fill in the feedback form. It's really helpful so that we can gather anonymous feedback that we can then present to the BSW team to make this as good as it can be and to work as well as it can for you. It means that I can update the teaching that we're delivering to reflect the questions and comments that people make. And it's also really helpful for my professional development as well. So hopefully that's a few good reasons just to take a few moments of your time to follow through the QR code and just fill out that form. It should not take long. And as I said, it's anonymous. Amazing. Thank you so much for your attention. And I look forward to hopefully, working with some of you soon and seeing the numbers for the end of life ICR continue to rise with all of the hard work that you're all doing. Thanks again.